Okay, so first off, I'd like to thank you all for joining us today for a discussion on contraceptives in Malta. I'd like to start off by asking you to give a short introduction of each of you. So, anyone would like to start?
Well, can I start?
Sure.
It's Marianne Manfournier. I'm the president of the Malta Chamber of Pharmacists, which is the National Association of Pharmacists, wherever they practice. And in the main, we represent community pharmacies. Pharmacists, sorry. Thank you.
Prof. Stabile?
Hi, I'm Isabel Stabile. I am a gynecologist. I'm also a professor at the university. Here today, I am in my capacity as one of the founder members of Doctors for Choice.
Emma? You're muted.
I'm muted, like word of 2020, sorry. So basically, I'm a lawyer. I've been interested in sexual health and reproductive rights since about 2014-ish, when I started university, and before that from junior college. I don't have qualifications in this subject as such, but because of my legal background, I use that as like a jumping off point for research and stuff like that.
And Sam?
So my name is Sam Vassallo. I'm a member of the pro-choice youth group Young Progressive Beings. I'm also a journalist with Loving Malta, and I cover a lot of social issues like the abortion topic that we're going to discuss.
Perfect. So to start off, do you believe that the Maltese society is ready for a revamped discussion on sexual education? Anyone would like to start?
Absolutely, yes. Absolutely, yes. I'm so delighted that not only KSU, but many other organizations on this island have finally woken up to the fact that this is something we need to discuss. We may not all agree. In fact, we don't all agree, but we need to start discussing it. And I'm delighted. Thank you.
Anyone else?
Yes, of course. I agree that there should be a wide discussion. It's important.
So, Maltese teenagers are amongst the most likely in Europe not to use contraceptives during sex. Do you believe that the current sexual health education that we give to teenagers is adequate? Emma?
So I've said this quite a few times before, but unfortunately the current sexual health policy was drafted 10 years ago. And I mean, 10 years ago is a really long time for a society to have, changed and become what it is today. And that's assuming that 10 years ago, the policy was even up to date then. So I feel like Maltese teenagers are not even getting remotely what they deserve in terms of sexual health education, not only because of the policy, but because of the lack of a curriculum that deals with exactly that. And it's a curriculum that needs to be across the board, church schools, private schools, state schools. It just needs to be properly formulated by doctors and scientists and pharmacists, and then put into the educators' hands to develop. That's my take.
Sam?
Just to bounce off what you've said, I totally agree. We need a standardized form of sexual education. I mean, just a quick look at the decade-old sexual health policy. They're still promoting abstinence as a form of contraception. There's absolutely no mention of abortion. There's no adequate understanding of the availability of contraceptives. We're not equipping young people and really the whole population on how they can protect themselves. I think we deserve excellent sexual health and sexual healthcare, as we always promote our excellent healthcare internationally.
Yes, if I can add to that, not much, because you've said everything that needs to be said, other than, unfortunately, from a clinical practice point of view, I see the consequences of that. I basically see, young women pregnant when they really don't wish to be pregnant, usually because they either did not access contraceptives or they were not aware of how they work and therefore how they fail or when they can fail. So when we talk about comprehensive sexual education, we need not only to talk about values, and I think it's extremely important that the sexual education be contextualized in values, but we also then need to provide practical information that goes beyond say no, because there is evidence, incontrovertible evidence now, which I can quote ad nauseum, that abstinence on its own does not work. So, we're literally hiding behind our fingers, my father used to say, when we pretend that it does. I'm not suggesting that we don't mention it. I'm not suggesting that we don't, again, say that it is one of the values that we promote, but we cannot stop there, because otherwise we will continue to have this type of problem that we see now, which is where young people seem not to be prepared, which is a shame.
Especially, may I add, especially in a country where abortion is completely banned, we should be advocating for the best sexual health education that there is.
Yes. May I? I agree with much that was said, especially with regards to the education of teenagers and maybe even younger. I feel that from what pharmacists tell us with regards to, for example, women acceding to their services, for example, when they ask them questions about the body, about what's happening before they dispense oral contraceptives or the emergency contraceptive pill. Women don't know much about their body, don't know how the products, the treatments work. And it's very important, first of all, that at a young age, one can decide, all the stakeholders, all those interested can decide on what form of sexual education should be given. It should be an all-round and robust education. Boys and girls, because we should be talking of both, although here, as we said earlier, we are all women. For example, there is an example of the very high numbers of males who do not use condoms in Malta, and young people. There are statistics which are shocking, and it comes from lack of education, but also perhaps from a male-dominant culture. We're Southern European, the macho culture, and so they leave protection to the woman, or for other reasons. And I think it's very important, therefore, that the sexual health policy will focus a lot even on education, besides the actual health services and outreach, etc. And that the young people are taught to respect themselves first and to respect their partners, and also to be well informed so that they can make good choices as to how to accede to legal health services, and also to be, as Professor Stabile has said, for example, that there should be a very good discussion on values, on respect, mutual respect, and on responsibility. So yes, of course, there's a lot to agree on. There are some things maybe that one would not agree upon, but then mainly I don't think that we can not agree on this.
Can I just add one last thing to the very amazing points everyone raised? I feel like it's also important, because no one seems to have mentioned it yet, that sexual health education is not just aimed towards cisgender hetero relationships. So there's a huge focus on relationships between men and women, and that is it. Sort of the LGBT community has been immensely underserved by sexual health education in this country, if you can even call it underserved, had they been served at all. Sort of there's a huge disparity there, and that needs to be tackled as well.
So continuing on the topic of sexual health education, do you believe that the availability of free condoms would emphasize the importance of good sexual health, or do you think that it could possibly encourage promiscuity? I don't know who'd like to start.
I don't know the answer, of course. I think we're speculating here, but if we can use the parallel of the free needles that we give out safely and effectively to drug addicts, and because they save lives, we know they save lives. Actually, to be honest, I'm not sure if any study to that effect has been done, whether condoms, in fact, giving out free condoms are effective in preventing pregnancy. I don't know the answer to that, or preventing sexually transmitted infections, because remember, there are two sides to this. Condoms should, in fact, always be used in conjunction with other forms of birth control. So I don't know whether that study has been done, but logic would suggest that it makes sense. Now, there is a cost involved, of course, but let's be clear about this. In the vast majority of cases that I know, although it is supposedly the male partner's responsibility to turn up with a condom, my advice to every young woman I see is carry one in your purse, just in case. So when he says, I ain't got one, I do. And there you go. Because unfortunately, all sorts of excuses come forward. You know, I don't have one. If they were free, I think it's quite likely that they would have one. And we know what the Maltese are like. Anything that's free is good.
May I?
If I may add.
With regards to...
Go ahead.
Go ahead, Sam.
Marianne, you can.
Okay, Sam or myself?
Yes, you can.
Okay, sorry.
Go.
With regards to availability of condoms, it was mentioned that 10 years have passed since the sexual health policy was published. It hasn't been updated, but over the years also the availability of condoms has increased, and they're widely available in pharmacies without any issues. And also they are also available out of pharmacies and dispensing boxes here and there, and then in different places. So I don't think there is a barrier to access to condoms. I mean, whether they should be given free or not, well, I mean, that is another issue. With regards to their use also, I think yes, they should be used. I don't know whether promotion of use and relation to promiscuity, well, that's, as Prof. Stabile said, used to be measured. I don't know if it has been. It may, I don't know. With regards to their safety, however, we all know that they're not 100% safe. So there shouldn't be this sort of lackadaisical approach to them. And also, it's very important, and it has been mentioned by my other colleagues here on the panel, that we address also the sexually transmitted infections and diseases. So, that's the issue.
Definitely. Sam?
Thank you.
If I may add to that excellent point, condoms may be more accessible today, but stigmas around using condoms and actually going to buy them are still there, I believe. So I think that if we were to equip our young people with condoms, break down these barriers, it's not a shameful thing to go and buy them, normalize it, just to normalize it, and it's not this kind of forbidden and funny thing. I think that could only benefit young people. I don't think that it's going to make them more promiscuous. I think, in fact, I haven't seen any figures as any of you have, but I believe that, giving people tools to protect themselves can only do good.
Can I also say something on this point? Unfortunately, it also stems from a place of privilege that we can say that there aren't barriers to accessing contraception, because there are barriers to accessing contraception for a lot of people. There are people who might be allergic to condoms. There are people who might not have the funds to buy condoms. And that doesn't suddenly mean that because you don't have the money for it, you're going to just not have sex. We know how it works, as in there are young people who are living on stipends who are now within the age of consent. So, I mean, these are people that need to be considered as well. Condoms are not cheap, as in, not gonna lie, having €85 and having to buy a €14 box of condoms is what? I don't know the percentages, not great at math. So if someone could help me out, that's a hefty chunk, you know what I mean? What's 14 out of 85? It's a lot. So there are barriers still. And further to that, I think it's important to note that back in 2015, we had tried to install condom machines on campus. And I genuinely thought that when I was in KSU, it would be one of those things that would just fly through. I really did not envisage, maybe that's like naivety, but I really did not envisage pushback on that. And there was pushback on that. So that was only, 5 years ago? And okay, it happened, but not easily. And I was also told that 2 years prior to that, they had tried and failed, which to me is like something I can't even comprehend. But yes.
Exactly. On a bit of a positive note, they're still there. So there are condom machines at university in both bathrooms. I don't know if there's anything else someone would like to add.
Yes, just one small thing. There's also an issue of debunking certain myths about condom use. It's not quite the question you asked, but I think there's a good place to talk about it. And that is, this idea that it somehow interferes with male pleasure. We need to get rid of these ideas. These are perpetuated from one person to the next. So that's going back to sexual education. If people are told how to use condoms, they're showed how to wear them, obviously on a banana or something like that, right? But also given the true facts, then we'll have less of these myths floating around which get perpetuated.
May I add something to that too?
Yes, of course.
At the end of the day, I think at the end of the day, it's all boiling down to education. So the education has to be robust, comprehensive, true, without any frills, and without judgment, of course, and evidence-based, and down to the level of the age group that one has in front of us, because it's part of life. And it's very important, I think, that we know very well how to go about living that part of our behavior as human beings. So yes.
Okay, so I'd like to move on to a different type of contraceptive that we haven't mentioned so far, the OCP. So over the past few years, there have been multiple instances where certain oral contraceptive pills have gone out of stock. As you all know, the OCP is used not just for its contraceptive, not just as a contraceptive, but also for other health issues that a woman may face. Do you believe that changing their status to essential drugs would aid in avoiding such instances in the future?
Absolutely.
May
I absolutely
I elaborate?
That maybe a limited amount, a limited range, doesn't have to be every single oral contraceptive on the market, but we certainly ought to have at least some oral contraceptive pills that are essential and therefore are constantly available. As the person who has to take the phone calls and the messages from women who say, oh, I was really fine on the one you gave me, but I can't find it, and what shall I do? And you go, well, let's go to the next plan, and then the next plan. No, I tried that one, I can't find that one either. This is really disturbing, really disturbing. Can you imagine running from one pharmacy to the other looking for this pill? I must say here pharmacists can be very helpful, because they will tell you it's out of stock. Don't bother going around for it, So I must say that I, in the Hilo Mil Kapell, as it were, that there is a lot of support from pharmacists with regard to sharing information. But yes, I would love to see oral contraceptive pills be essentially on the essential medicines list.
With regards to shortages, of course, there are a number of different preparations of the oral contraceptive pill, but obviously each and every woman would be stabilized and maintained on a particular brand, going into different trade names, but different types of preparations, let's put it this way. And yes, when there is a shortage, and that is a problem, an issue, it's not only for oral contraceptive pills, it's for any medicine. Over the last months, there were some reports in the press, many about some particular brands. With the onset of the COVID pandemic, unfortunately, and also with Brexit looming ahead, it was the end of the year and beginning of next year, there have been some issues with medicines in general. With regards to shortages, with regards to Brexit, because of stockpiling, even in Malta, some of these shortages did not affect us as they have affected the world and the EU. The shortages can be a result of several issues, as Professor Stubber.
I think Marianne's connection broke. If someone would like to elaborate, I'll elaborate further.
Can I just say one thing?
Yes.
Professor Stabile mentioned how a lot of people have to change their pill. That has implications, I imagine, that you can speak much more in depth on than I can. I know of friends, obviously, who've had experiences with it, and it's incredibly unpleasant. Could you elaborate further on what that actually does to a body, like the hormones and stuff like that?
Yes, yes. So just to be clear, there are two main types of oral contraceptive pills. Okay, there are what's called the combined pill, the ones that contain estrogen and progesterone, and then there is the so-called mini pill, which contains only progesterone. So we put them all together, but actually the side effects are different. So we choose the type of combined oral contraceptive pill to match the needs of that particular person. So for example, if they have acne or if they've got a hair problem, then we might choose one particular type of progesterone, etc. So yes, matching the needs of the person with the specific type of contraceptive is very important. Now, it's not always important. Sometimes they just need a good, safe, relatively inexpensive oral contraceptive pill, and there are several of those on the market. But sometimes we need to be very precise, and luckily we have a spectrum. We have a largish variety, not maybe super large, but we have, quite a good variety of contraceptive pills at different doses. So once you have found the right match for that person, if that match suddenly disappears and there is no replacement, because sometimes there is, sometimes you can, try something similar. But if there isn't, then we are stuck in a situation where your person is not being served, is not actually getting the medical treatment they need. That is the issue, really, because using, it's not just a matter of side effects, as in this pill suited me and this one doesn't. That is also a problem, but not being able to deal with the precise conditions that that person has is an issue. It's an issue. And I think we lost Marianne again, but I'm not sure she wanted to say something.
Yes, Sam?
This issue about contraceptive shortages, I started writing about in March when the pandemic hit, and reaching out to the health ministry, it was, as my colleague said, because of Brexit and procedural delays. It's become a normalized thing now. We're still dealing with these shortages, as now we're dealing with HIV medicine shortages for the same kind of reasons. Putting at least some contraceptives on the essential medicine list will, to a certain extent, combat these shortages. It will also inform patients when their medicine is out of stock, so that we don't end up going to 10 pharmacies and playing Mary and Joseph knocking on each door and everyone is close to us. And I think honestly it boils down to Malta just having to take sexual health in general more seriously. Hopefully when the COVID-19 pandemic subsides and we can get vaccinated and hopefully things stabilize, I think it's our duty to really put pressure on the government and make sure that this is an absolute top priority now.
I agree.
I'm not sure hearing me, because at some stage I could see the screen.
Yes,
I don't know whether I was. So with regards to this issue, as I said, the pharmacists themselves have no control. I mean, the pharmacists, the community pharmacy, have no control over the supply or over the shortage.
Unfortunately, it seems we lost Marianne again. She'll be joining us soon, I believe. So in the meantime, hi Marianne. In the meantime, what I'd like to ask, would you... So, I'll continue in the meantime until your internet stabilizes. So, do you believe that the fact that the OCP is not considered an essential medicine currently infringes on a woman's right to access to adequate healthcare?
With regards to the point of availability as an essential medicine, I think we have to look at what is also a critical medicine. I don't represent the Ministry of Health here because it's the Ministry of Health that would decide on whether a medicine moves from private to private.
It's quite unfortunate. So, would anyone else like to continue?
If I can, I think what Mariam was going to talk about, maybe, I don't want to put words in her mouth, but she might have been wanting to speak about formulary versus non-formulary medicines, you know, medicines that are critical and that we should have available. And of course, we can go there if you want, but there is also the question of cost. I don't think we can get away from this. It's a practical cost, but many countries, the UK is just one of them, provide contraception, particularly contraceptive pills, to residents of the UK at a greatly subsidized price. Okay, they don't have to be completely free. In fact, they're not. I think there's a small prescription fee they need to pay, but at a greatly subsidized price. So we can overcome, again, as we were talking earlier with condoms and their cost. Cost itself isn't necessarily the issue. Sometimes it's even a matter, as Emma was saying, of looking at things from a position of privilege, you know, going to a pharmacy when you don't have much money and asking for something. It's more the matter that you have to ask for it. In any case, I am committed, I'm completely convinced that these should be essential medicines and they should be available at ideally, no cost. But if we can't get there, considering all the other expenses we have to face as a country, I think they should be subsidized, yes. I think it is entirely unfair, sorry, Emma, just one last point. I think it's entirely unfair that the burden of cost of the purchase of oral contraceptive pills, just like sanitary ware, is, you know, only on the female partner. I think that is just outrageous, you know, completely outrageous, to say nothing of the time it takes and the cost of going to see a doctor, getting the prescription, running from one pharmacy to another to get what you need. Why should this be only the woman's responsibility?
I think also this might warrant a
If I may, when there's a shortage, it can also affect the government formulary. So
should I
Yes,
continue?
Emma?
Okay.
Yes, yes.
I think this is also relevant when you talk about, for example, what is contraception that is something that should be free. So, okay, we have the OCP and we're talking about that and considering that being subsidized or free. But what about other forms of contraception that might be more suited to the person taking them? So, for example, the coil, and again, Professor Stabile is the expert here, not me. I can only talk from my own personal experience, but I also have a lot of friends who the OCP did not work with, made them incredibly moody and hormonal and upset. And, you know, it's not for everyone. So there are other things like the implant as well, for example, that need to be explored and perhaps heavily subsidized, if not made entirely free. Again, I would be of the school of thought that they should be entirely free, especially since we live in a country that boasts free healthcare and a socialist government. But, you know, that's
yes, Emma, you're right, of course. And except that to add to that, things like the implant and the IUD are, first of all, more expensive. And secondly, and another reason why they should be considered essential, there is a doctor's input, okay? Not just a prescription, but an actual, you know, procedure, minor procedure to insert the IUD or the implant at a cost. And this is another issue, you know? So it's not possible to obtain a hormonal IUD like the Mirena or the JDES on the NHS unless you use an excuse. Okay, so we're lying, that's what we're doing, to ourselves and to our patients by saying she has heavy periods. So we need to use a hormonal method, a long-term hormonal method. Why not use the JDES? Why not use the Mirena? Wonderful idea. Well, but come on, we're just kidding ourselves, right? I mean, we're lying to ourselves, we're lying to our patients, we're even doing it barefacedly. This is ridiculous, right? If a person needs that treatment, it's the best, if that person needs that particular contraceptive method, it's the best for them, then they should have it. And we need to figure out how to pay for it. And that's not too difficult. We could just sell 1 or 2 more passports. Sorry, joke.
If I may, because I think I wasn't online. I'm sorry, my internet seems to be playing up. As a chamber, on behalf of the chamber, I'm talking, and we noted, for example, that the government, the Ministry for Health, has announced many times its policy to move medicines from private practice to the government formulary, so for free, what we call free medicines. Of course, there are a long list of, probably a long list of patient groups who lobby for their treatments and for new and innovative treatments to go on the government formulary. And government prioritizes and have their own objectives. Certainly, especially for endocrinological use, in certain conditions where the OCP is indicated, I think that would be quite a case that they should be available. With regards to their use as contraceptives, perhaps, when it is not what I believe or what I'm saying for it to be this way, but probably they would go on the back burner, you know, in place of all the other life-saving and other treatments, and possibly that could be the reason why some medicines, some OCPs are not available on the GFL. But it's also something that could be discussed, I think, by all stakeholders in the ambit of the sexual health policy. Why not?
Anyone would like to add anything else?
Well, just one thing. Not having contraceptives or other forms of contraception available cheaply, preferably free, widely available, preferably easily accessible, means that our hands are tied. So we have, on the one hand, we're not able to provide good sexual education. We're not able to provide essential services to essential access to contraceptives. And then when things fail, we're not able to provide an option out. So this is just, to my mind, a completely ridiculous scenario. We're wrong. We're playing it wrong on all three. And one last point I want to make here is that you may know, but most people think of Doctors for Choice as being pro-abortion. Actually, we have 4 main goals, and the legalization of abortion is one of them, but it is the last. Our first 3 are equally important, and that is access to sexual education, comprehensive sexual education, access to free contraception, and the third is to decriminalize abortion, but we will come there later, I would imagine.
And can I say something to add to what Professor Stavile said? I really think it's important to mention what she mentioned about us failing on all 3 fronts. I think that is the peak of government and opposition's hypocrisy at this. Our representatives in Parliament are anti-choice. For you to be anti-choice and to not be a hypocrite, you need to be doing everything you can to make sure abortions aren't needed. No one has done that. No one is doing that. And it doesn't seem to be happening or on the horizon anytime soon. So we've created a situation that is completely untenable, where women are ending up pregnant because of a lack of sexual health education, because of a lack of accessibility. And then we're telling them, it's a deal with it, or sending them to prison, which is another alternative we like to keep, on the back burner as an option, which is ridiculous, as in this is unsustainable.
Ultimately,
yes,
just to finish and add to your point, ultimately we're just punishing poor women. We're punishing people who can't afford to, pay for expensive IUDs, which cost anywhere between 300 and 500 euros, as far as I know, who can't, just travel onto a flight, book leave, sort out all of that out. So essentially, we're just kind of penalizing people who can't afford it and saying, deal with it yourself, see what you're going to do.
So on this topic, it can, I think, in my opinion, can definitely be argued that Malta's traditions, Malta's customs have influenced our views as a society on sexual education, on contraceptives, on abortion. Do you believe that these certain views are changing along the years, and where do you believe they are going? So anyone?
I think that a lot has changed on certain scenarios. However, there are other things. Let's say so, principles, morals, values. Some things need to change. Others, the values of Maltese society, for example, where are they? I mean, if you look at today, you know, there's a lot of liberal and utilitarian. You see, I mean, I don't want to be judgmental or because of my years, for example, but I am a woman, I'm a mother, I'm a grandmother too, I'm a health professional. And I have many interests, and I talk to a lot of young people because I've spent a long number of years teaching at university, for example, and we still work very closely with our young members of the profession and students. Of course, I don't know if there are any. I was under the impression that there was the Malta Health Sciences Association. I don't know if the pharmacy students are involved, for example, in this event. So we as a chamber, we've worked often with them, for example, on our campaigns, health campaigns, and on Science in the City festival, for example. And so you hear a lot of their views, and of course, you know, you look at what's happening in health, for example, all the developments. So I think it's already very important that we are here discussing, but we are, as was said earlier on, that we're all women here, we're the men here. You know, we should all be talking together, and all the genders and all the interests in this area.
To be quite honest, we really wish to have a man on the panel.
Many times it's women talking, women about their gender pay gaps, women about their rights, women about contraception, women about this and women about that. It should be, society should be men and women, you know, I mean, obviously. And as the lady said, all the genders too. But let's face it, it's the women who have the issues with their health, it's the issues who have with their sexual and reproductive health. And I think we should be, yes, assess very carefully where we stand today and bring along and see that we are understood even. After all, we have a very high percentage of men in Parliament, as was mentioned. So we need to have an open discussion, yes. I'm talking here of legal sexual health services today. And I think that would bring us perhaps to a discussion on other aspects. Society is made up of different views. There are those who are, as you say, pro-choice, and there are those who are pro-life. And so everybody has the right to a choice, let's put it this way. And I think society has to provide for the different values and the principle of right to thought and conscience. This is very important for healthcare professionals and for other professionals. You are a student, there are students here, and I think it's important that this is considered and understood. The ethics of their profession is a very important value. It's not only the science or the professional practice, but also the ethics. And I think we need to all understand and respect each other's views, but help and be there to support, especially the woman, because I think here the main focus is the woman, and be there to help and support the woman. And where there is also the application of freedom of conscience, the state has also to provide the legal services that are available, whatever they are. Today, this is where we are, for example. That is, you know, a point I wanted to make in this discussion.
If I could, oh, sorry, yeah, Sam, you go ahead.
Okay. If I could just add to that comment on, you know, this being a women-only panel. Unfortunately, sexual health, the same with domestic violence, the same with the abortion problem, tend to be lumped as a women's issue, something for women to deal with on their own, figure out, come up with a solution, so on and so forth. Sexual health, possibly women and gay men seem to be, you know, it's kind of seen as their kind of problem. I think in terms of whether values are changing or not, I think my work with young progressive beings, I've definitely seen a change. Even from when I was at school, I'm 22 years old. I went to a Catholic school. My sexual education was don't have sex, or suffer the consequences on your own, basically. I feel this is the first generation where young people aren't so aligned with political parties, aren't so aligned with all the views of the Catholic Church. So, and we have the internet, which is the biggest democratic achievement in the 21st century. So I really believe that we are more liberal. We're seeing what's happening, outside of Malta. We have this chance we have social media. We can discuss our opinions over there. I'm definitely seeing a change in values. Now it's a matter of legislation catching up to that, about us understanding what needs to be done to rectify the situation. And so I'm very excited to see what actually young people in Malta are going to do when they find a voice, at the decision-making table, out on the streets as we do in protests. So I'm very optimistic myself.
Yes, just to add to that, and of course I entirely agree that everyone has a right to their opinion. What we do not have a right to is to impose that opinion on others. This is my problem with the whole, what I like to call anti-choice. I know some people call it pro-life, and that's fine. Again, they can call it what they like, but I like to think of it as not giving me a choice. Now, there are reasons for it, and again, I respect the views of those people who have those reasons, absolutely. But to my mind, what doesn't make sense is to impose those views on other people. Marianne mentioned the right to, conscientiously object, for example, to provide a service or whatever. And again, I personally have a problem with this. I have a problem with conscientious objection without the concept of making a referral. So fine, if you don't want to do something yourself, you have a reason for it, that's perfectly fine if that's how you feel. But you also have a duty to care. We all have, as healthcare practitioners, a duty to care and a duty to look after, a duty to, look after the healthcare of that individual. And if that duty includes doing something which you personally or one personally conscientiously objects to, then the other side of that coin is that one needs to make a referral to someone who can and will. So I just wanted to put that context in there.
Can I also point something out? Maybe Marianne could shed more light on this.
Sorry.
Don't worry. Essentially, I'm just wondering, the issue of conscientious objection, did that ever come up before the MEP? Was it when Viagra became mainstream? Did that ever come up as an issue? I'm only asking because I'm 28 and I only started reading the news maybe 16, 15 years ago. So I think Viagra was a bigger deal before then. So I might have missed it. So I'm just wondering.
I don't know. I wasn't living in Malta then, so I have no idea.
As far as I know, Viagra isn't a contraceptive.
No.
I'm going to do contraception.
It's not form.
Let me tell you, conscientious objection. You are a lawyer?
Yes.
Conscientious objection is something that has existed since times immemorial, especially in the healthcare professions,
Yes,
and this part is also harbored in the ethical codes of pharmacists, of doctors, nurses, I suppose, and others who are, on the front line in healthcare, basically. Of course, as Isabel said, one should not be judgmental. One should not, how shall I say, well, not be judgmental. I think that is the best way of putting it. And yes, for example, in our guidance to, even in the Code of Ethics itself, of how it is interpreted, and in the guidelines that the Chamber has drafted for pharmacists in dispensing and advising the emergency contraceptive pill, they are, of course, reminded that they should not be judgmental, that their moral conviction should not be, how shall I say, reflected on the person in front of them, etc., and be supportive, and also referral. Although in other, for example, we've seen other ethical codes and legislations elsewhere, the recommendation is that the state should provide for access to those legal services where there is conscientious objection applied. I must say, and I have a lawyer in front of me, so maybe you're interested or you have yourself done this research, because we have done some extensive research, because at the moment, as you may know, there's the Equality Bill in front of Parliament, and we are making submissions on that. That there are numerous European conventions and charters, and even international ones, where the right to freedom of thought, for example, is guaranteed by these charters, by United Nations conventions and EU. And also there's a recommendation of the Council of Europe, which says that the state should provide to guarantee the right to conscientious objection. But I fully agree with the fact that, the professional, whether it's a doctor, a nurse, a pharmacist, or whoever, should not be judgmental, should treat the patient with the respect that is due, and also should be informative, should inform, for example, that here, for example, let's talk about the ECP, about the emergency consideration. So, no, I don't stock it because, I object to it, however, and you can be referred, or there is the state that provides for that service. So access is not denied, because I think the question somewhere was, are you not denying access to the woman to the treatment or the whatever?
I don't
think it's excessive enough.
over something.
I want to speak, and then I'd like to make a point.
Can I just counter that just for a second? If conscientious objection has ever come up with regard to anything that's not the MAP, that was what I was going for. Has it come up before? Because I don't remember that it has, but you obviously have a wealth of experience in the sector, being, the president of the chamber. So you will definitely know more than I do on that. Has it ever come up before?
Yes, it can come up. It can come up it can and has. I don't have a sort of a history here in front of me, but it is there, and it has come up because professionals will tell you, for example, in the case of pharmacists, when they see, for example, certain prescriptions for certain medications, which may not be for contraception or for use as a morning after pill, let's put it this way. It could be also for certain products, medicines, which may produce euthanasia, for example, which is illegal, okay? And even if it were legal, there would be people, let's put it this way, because before we were talking about how things have changed, or have they changed? We have a very vast a population of pharmacists, and Malta have quite a number of pharmacists practicing. The majority of members of the chamber practicing community pharmacy is the core profession practice, okay? And of course we have, a spectrum of people, some who are probably you would consider them as pro-choice, or others who would be considered as pro-life. The pro-life would have conscientious objection, of course, for the MAP. But it's not only for that, it could be for other reasons. Let's face it, in general, a pharmacist may refuse to dispense, even maybe it's not just conscience, even if he has a query, or he doesn't thinks the dose is not correct, or it's not suitable for the patient, he can go back to the doctor or refer back to the doctor, or refuse to dispense. It's within, we are not robots, we don't pick up the product and just give. I
totally get what you...
I can't hear.
Can you hear me now?
No, yes.
Yeah, sorry. So, but that's not conscientious objection, though. Of course,
no,
pharmacists need to do...
That's practice, but it can happen. But with regards to, for example, assisted dying, you can tell from the prescription and from the dose. And even the case of contraception, let's put it this way, all right? Before the onset of the emergency contraceptive pill, the combination and doses of the OCP, which could be used as an emergency in some cases. So you would still have the conscientious objection coming in and saying, sort of, that is, So, that's it.
But the only thing you've that's something that has gotten the brunt of conscientious objection have been.
We came more to the fore with the onset of the ECP, because the ECP now is more, first of all, it's in the media all the time. And secondly, there was a lot of emphasis at the time of its introduction. Obviously when it came, it was registered as a pharmacy medicine, so without a doctor's prescription. The chamber went along obviously with that. We had a discussion even at parliamentary committee level. We made our submissions. We guided the pharmacists and also insisted there would still be the right to conscientious objection. Basically, that's it.
Okay,
so definitely the issue of
before, since 2016, more than ever before. Let's put it this way.
I understand.
Yes, definitely. The issue of conscientious objection is applied mostly to the morning after pill. What I'd like to know is your opinion on the issue of conscientious objection, especially Prof. Stabile and Sam.
If I can I go before you, Sam?
Of course.
Because I wanted to tie in with what Marianne was saying here and the guidelines that the Chamber provides to its members. I'm delighted to hear that there are the issue of being respectful and, of course, as expected, profession. But I can also, I was also glad to hear that they are being advised to make a referral if they are unable to dispense the emergency contraception. The problem we have, and I think we need to be very practical here. First of all, there are certain days and times of the day in certain parts of Malta and Gozo where, unfortunately, emergency contraception is not available. It is simply not available after about noon on Sunday. And even then, it's only available in some pharmacies. So if you happen to be in the unlucky situation where you are just before 12 o'clock and you need emergency contraception, you go to your local pharmacy that happens to be open in your town or village, and you find, unfortunately, someone who is conscientiously objecting. And even if that person does refer, and I'm afraid I have to tell you, Marianne, that sadly, I've had many reports of women tell me that their pharmacist did not want to refer. Now, I'm not suggesting that that's the camera's guidance. I'm sure it isn't, but unfortunately, this is the reality of today, where some pharmacists, I hope very few, but I can't prove this, are unfortunately not referring. So women remain without the emergency contraception. So going back, that young person who, or even not so young person, is unable to achieve what she needs, which is emergency contraception from noon on Sunday. She can't go to Malta Day Hospital pharmacy because they don't have it either. And we heard yesterday from the Deputy Prime Minister, Minister of Health, that it is only available to persons as inpatients after being raped. We also know, unfortunately, that most women who are raped are not admitted to hospital. So effectively, it is not available all the time, and it should be available all the time. So what we are saying, and what I'd like to ask, and that's what I wanted to speak to you about in my emails, I was hoping that you'd get back to me. What I wanted to ask is, can you, as a CAMRA and the representative professional body for community pharmacies, ask your members, please, would you come forward and put together a roster? Now, I would...
No, they work by roster. On a Sunday and Saturday, they work by roster.
After 12 o'clock. That's my point.
The roster that we have at the moment, and they offer, they are open for very long hours during the week.
Yes.
And as you know, they are the few, I think they are the only professionals that actually offer a service on a Sunday in that manner.
Sorry. Doctors provide that service 24/7 as well.
Many do on a Sunday.
Pharmacists are as important
on a Sunday. I love my doctor friends and colleagues, but you know,
Marian, I'd like to
that's
ask
how
you-
things stand at the moment. Let me tell you, Isabel, that's how things stand at the moment. You know, even from a legal point of view, etc. We have extended, well, not very recently, but very recently, the Saturday afternoons, for example, by roster. There are some pharmacies that are open for very long hours, that don't close, especially during the week, that open on a Saturday irrespective, because they're allowed to do that, irrespective of the roster, but a roster is guaranteed. There are some pharmacies, especially there are particular pharmacies in Gozo that open for very long hours, even, and everybody knows this. Gozo is a bit sui generis, let's put it this way.
Yes, the problem, Marian, this is all true.
I know. No, just me finish.
Essential coverage all the time.
You know, with regards to government supply, because we were talking about that government should also ensure access. It's of course very important that it is given as an emergency for when women of whatever age are unfortunately raped, so it's an emergency that is available, and for those that do go to hospital. And with regards to the inpatient pharmacy supplies medicines which are normally only available in private practice, but after the closing hours of pharmacies.
Yes.
Now, if it is not available at the pharmacy after closure on Sunday, that is a matter that could be taken up.
But my point is, it's not available today.
I know. No, I understood.
Yes. So I'd love it if you'd ask your members to push forward for this. And I interrupted you, Sam.
No, this is fine. Very valid points. I mean, just to extend on your point, it is not available at the outpatient pharmacy at Malta, our national hospital, which gives the message that only if your body has been violated do you deserve to get this medicine. And to me, that is beyond words. I mean, unfortunately, today there was a study conducted, I think, a month ago that found only 64% of pharmacies actually stock the MAP. If you are in Gozo and it's a Sunday, tough luck, you have to go to Malta to get this medicine. It had to be a new political party, Volt Malta, who came up with this map to show which pharmacies actually stock this. It had to be, a third party. And I mean, this is ridiculous. So why are women half the population on the back burner when it comes to such an essential aspect of their health? This idea of conscientious objection, like you, Emma, I've only ever heard about it. I've only ever heard about it when it comes to women's bodies, when it comes to contraception. I know that we're debating this.
The conscientious objection is used when there is the consideration of how the emergency contraception works, which may be about the patient. That's why it came up with the map. It does not hide about it. That's what it is.
But even if that
there
is
is no evidence for that
remains as it is.
Exactly.
Can we let Emma finish your point, and then we'll move to Sam and then Marianne? So let's go with Emma first.
No, please, Sam, continue. But I feel like you're being diluted.
No, I'm sorry if I interrupted, Sam. I'm sorry. Maybe I interrupted your train of thought. But because you said I only heard about it. It doesn't mean anything if you just heard about it. The conscientious objection principle is there. It has existed for a long time. It is something that should remain there. It should be in the law, actually.
I understand.
It's provided for by law. That's it. But it came up to the fore, yes, because then the MAP came in and there was a discussion of how one works and another. Women should be informed that there's one that works over 72 hours, another over 2 hours. There's a lot of papers published and you can read them. They should know how it works, and that there might be, or there may be,
So let's go to Sam.
Okay, so as someone who's not has no knowledge whatsoever in the medical field, I can understand medical objection to giving some kind of drug or whatever, but conscientious objection from my understanding is, okay, so where do we draw the line on this? Does this mean that you can conscientiously object to someone of a different ethnicity and not serve them?
No, don't go there. It's got nothing to do with equality and with racism.
Let's just let Sam point, and then we'll go to you, Mary.
Sorry.
It just sounds, I'm not implying that that is possible. I'm just saying that to me, it sounds like a very slippery slope. And the fact that it is kind of accepted when it comes to regulating women's bodies and only ever talked about really in this kind of case, to me is concerning. That's my point.
And I honestly couldn't have put it better. That is exactly what I was trying to say. I feel like the concept of conscientious objection is important. If you believe that that is an important thing, then so be it. But it loses a lot of legitimacy when you realize that it only came up over the topic of control over women. And I feel like had it ever come up before and in other situations, and had it ever been made an issue before, which if it were really an issue before, it would have been in the papers as well, as in, we don't live in a country where you don't find out what's going on, you know, kulħadd jaf kollox fuq kulħadd. So it loses a lot of legitimacy to me. And again, I think I need to reiterate what Sam said, that this is not talking about medical objection, as in interactions with other medication you might be taking, or you think the prescription was written badly, or it's too much, or maybe there was a mistake. That is totally like the scope of your work, in my opinion.
To make nothing to do with conscientious objection.
Exactly. That is exactly what I'm trying to reiterate. It has absolutely nothing to do with it.
Nothing to do.
I think conscientious objection when it comes to the morning after pill is particularly interesting because of the fact that the morning after pill has a time constraint. So that is something that has to be considered. So in situations where there isn't that time constraint that the morning after pill does impose, what is your opinion then on conscientious objection?
You're asking me?
Any of you?
No, I just wanted to point out that it's not a question of that it comes in only to control, as has been said, a woman's body. I'm a woman myself.
To what extent are your morals allowed to dictate what is allowed or not? That's the question.
Because there can
morals are intangible.
There can be a scientific doubt, let me put it this way, that it can be a motivation. Now, it's only the woman who may or may not carry the embryo that will develop into a baby and a human being. So it's natural that conscientious objection comes in with regards to life. So it's either in the case of pregnancy or not, or in the case of end of life. That's it. Where conscientious objection comes in. Where else can it come in? I mean, there can be other issues. It might come. You might have a conscientious objection as a lawyer, for example.
Except you can't do that. You can't just refuse to
do that.
So, Emma?
Because you don't want to, though. Anyway, what I was saying was...
Let me tell you, the pharmacist practices, according to science and conscience. That makes him a healthcare professional.
Exactly. Science.
So, Emma, can you finish your point?
Science is really important there. And abortion is illegal in Malta, completely. You know this. Everyone seems to know this. If abortion is illegal in Malta, explain how the MAP is abortifacient and sold legally.
The emergency contraception pill, the preparations consist of two types. One works over 72 hours pre-ovulatory phase. Professor Stabile can explain this much better than I. So I'm speaking to you as a pharmacist, knowing how these medicines work. And so, you know, if it's not taken after 72 hours, if it's taken after this, probably doesn't work. Let's put it this way. And the other one, which contains a medicine called ulipristal acetate in 30 milligrams, is first of all related to mifeprostone, which is a drug, which is the abortion pill. So it's not legal in Malta, so, right? And it works over 1 to 2 hours, all right? And although it is claimed in the SPC, which is the document with the minimal scientific information that is published by the MAH holder, by the manufacturer, okay, and is approved by the Medicines Agency, by the European Medicines Agency, which gives the green light for these products to come on the market. However, over the 1-2 hours that it can work, because it works over 5 days, it can work, you know, over 5 days. It may be, and from scientific publications that there are out there, okay, that one can research and read, it may be that since it continues to work for a longer period, I'm just putting it simply, all right, it may make the uterus lining, all right, how shall I say it, not adequate if there's fertilization for the embryo to implant, okay? So that is an abortifacient effect. Now, if there is the slightest doubt and moral conviction, okay, that happens to a person who is pro-life, okay, they can decide by thinking and freedom of thought and conscience that they do not want to stock or dispense this medicine. However, I said before, they can't be judgmental, they can't be disrespectful, there's nothing to do with ethnicity or racial discrimination or whatever, all right? There's nothing of that, that's illegal, we can't do it. No doctor or pharmacist can do that, no one can do that, all right? But yes, you can decide to say, listen, in all conscience, I cannot stock this and dispense it. And that's okay. However, in our guidance, yes, we told our pharmacists refer. In other jurisdictions and recommendations for legislation, in fact, there is the fact that if the pharmacist feels that by referring, he is sort of like collaborating in actually dispensing, which is not clear, all right? He's not sort of letting go of everything. Then it is the state that should have access for something that is legal. Yes, it's legal, it's on the market, it's there.
But if
okay? One last point is that a pharmacist is not a robot. You know, we just depend on just, you know, you have your medicine on the shelf and you dispense, you give it.
Which is why I tried to reiterate what I reiterated before.
In certain media, in press releases by different people who are not even here, and maybe others, so I won't mention names. You know, we're saying, you know, pharmacists should sell the pill and should do this. And whoa, mela l-spiżjar tal-ħanut, mela l-mediċini oġġetti ordinari tal-konsum, mela aħna robots, le,
But I also don't.
So, Emma?
I don't expect to go to a doctor, for example, let's say I smoke 20 packets a day, and I go to an oncologist, and she tells me, no, because you smoke, I don't want to treat you. These are things that are unheard of to me. These are things that shouldn't exist, especially.
Let's let Emma finish her point.
That's different.
Continue, Emma.
How is it different? How is it different?
It's different because most of the conditions that we have, although some are genetic and or environmental or whatever, or it's due to how we live. Allora we can say that we won't treat anyone, but this is different because it's life. If you have a doubt about about how the product acts, you can conscientiously object to not dispense it or stock it. That's it. And you are not depriving the woman from accessing the service because she can access it elsewhere. Wait a minute. If there is a limitation or a barrier to her access it, then we address that.
Yes.
You know?
So, Prof. Stabile?
But don't take away the right of the
Just let Prof. Stabile would like to make a point.
Yes, I'd like to make a number of points.
Go for it.
Thank you. Because there are a number of misconceptions out there. Marianne has rightly said that there are two products and how they work, and I won't disagree with her. But we also need to look at what the literature says. And we also need to remember that the European Medicines Authority, when it created, when it collects the data that it collects, does so by looking at peer-reviewed mainstream journals. You know, and there is extensive literature out there that shows unequivocally that the medicine that she's referring to that works over 72 hours, it's called ELA-1 in case you wanted to know, works by stopping or delaying ovulation, and therefore it prevents fertilization. There is no evidence at this point in time that that product actually prevents implantation. In fact, if ovulation has already occurred, it no longer works. It doesn't work, it's not effective. So while it is true that some people have proposed, you know, that there is some evidence, some literature out there that perhaps might indicate that there is an effect on implantation, the reality is that these studies, whatever they are, have somehow not reached the level of the European Medicines Authority. I mean, really and truly, if there had been any doubt whatsoever that these products cause abortion, given the laws that we have in this country, they would never, ever, ever have been approved. So the fact that they were approved then and remain now, even though, as we said, there are some limits to accessibility, simply means that we are following science. Now, if a pharmacist in this case wishes to read up and has found other evidence, and somehow that evidence hasn't filtered up to the European Medicines Authority yet, somehow it has not reached, you know, their consciousness, and wishes to base their choice, conscientious objection now, based on this, their read of the literature, which, as I said, is not mainstream at all, then they are denying women access to a time-sensitive product. This, to me, is bordering on criminal. I'm not suggesting pharmacists are criminal, please don't get me wrong, but the decision to stop a woman from getting access to the emergency contraception when we know that if she does get pregnant, sadly, she now has no way out other than have a baby, basically, or travel if she can afford it, because let's always remember that we are talking, all of us around this table, from a position of privilege, the privilege of education. We are very, very fortunate. We spent years learning how to think, and yet many, many women in Malta, not just women, but persons in Malta, do not have that privilege. They are not necessarily able to access information, right? So as you well know, our website, Doctors for Choice website, provides plenty of information on how to access emergency contraception and also various types of abortion. I'm just trying to make the point here that evidence, scientific evidence, must be robust, and we cannot have vague ideas out there and saying, oh, well, I've read a paper that says that maybe under certain circumstances, therefore I will not dispense. And worse than that, not only will I not dispense, but I won't refer, because perhaps referring means that I'm somehow aiding and abetting the possibility of an abortion. That, to my mind, borders on the criminal.
Really, Sam wanted to say something?
I have nothing to add to that.
Okay.
Well, I do. The scientific evidence that Isabel talked about and that is taken into account by the European Medicines Agency, all this is available online. There is a committee which assesses, does a risk assessment before they go up to another level, where there is a committee that then makes the recommendation for a product to go on the market. So one can look at all the deliberations of the different members, who are all enlightened people, experts, yes, of course. And we do follow, you know, what happens at that level. There is, I think, of course, if one wants to drive a point, one will say that all the body of evidence points at one direction. I think one has to be more broad than that. With regards to both pills, in fact, both preparations, they will depend very much on for example, there is out there, sometimes our pharmacists are criticized because they ask questions. They have to ask questions because you have to know at what stage which pill is more adequate than one than the other. And also, they are asked questions about their periods, about when they had the intercourse, when was their last period, the knowledge that they have about the way their body works. So there is a fine line here too about the information that is given, and so the effect can put the doubt and the concern into that pharmacist who wants to use his right to conscientious objection. I don't think that we can agree on this point, because if we are a priori against the principle that conscientious objection can be applied, then it's difficult and we have to agree to disagree, I'm afraid. But one cannot just throw this out of the window. On the other hand, as I said, it is important that there is no barrier to access. Yes, I agree with that. And so we should address that. I think I'm all for that. And we discussed several points that I think could be placed on a table for a discussion within the whole scenario.
So to conclude on the topic of conscientious objection, it's Sam and then Emma, and then we'll move on to the last question. Sam?
I think this idea of conscientious objection right now and hurdles to access can't be tackled separately, because right now access itself is severely hindered. There's only, as I said, I think 64% of pharmacists that supply the MAP. So you, as a pharmacist, morally objecting to supplying this is severely hindering women's access to the pill. If we were in a scenario where, there was adequate access, it was affordable, there were schemes, people were knowledgeable about all their options, then possibly that could be, a point of reason. But at the moment, access is severely limited. We're not at a point where I believe citing your moral objection to something which is factually not abortive is valid, unfortunately, because women in Malta are taking the brunt of this, unfortunately, from a government level, with a dire sexual health policy, from a lack of standardized education. Unfortunately, religious schools can choose not to teach factual sexual education. So at the end of it, we are taking the brunt of it.
Marianne, correct me if I'm wrong. Before you mentioned two types of morning after pills, right? There's the one that's 72 hours that you didn't seem to have any evidence on that it could possibly be an abortifacient, and the one that's 120, right?
Yes.
Right. So if
there are pharmacists who stock the 72-hour one.
So that's exactly what I'm getting to. So let's say that everyone wants to base their conscience on this one piece of literature that Professor Sabile went into at depth.
One piece of literature.
However many it might be.
Okay.
We made to have considered it as valid. Let's say that is correct and they want to base themselves on that. Why don't they all stock the 72-hour one? Why do they just not stock it entirely? And how is that not control over women? Because if that were the case, then someone would tell me that, of course, we stock the 72-hour one. We want you to have access to this. Of course, we want you to have access to this. Not suddenly both of them. Or
Emma, it's all a question of, the right to freedom of thought and conscience, and the right of women to access a service, access the treatment. You have them on both, on the balance like this. You're a lawyer, so you're used to that. The balance is your symbol. So you have here the right of the woman to access herself, the morning after pill, and here you have the right of the pharmacist, the healthcare professional, to conscientiously object. Now, at the same time, you have Sam mentioned this, what was it, 64%, he said? We had seen that study, and we also checked with our colleagues in Gozo. For example, the results with reference to Gozo were not correct, because many pharmacists phoned up and told us, I stock it, we have it, we have this, we have that. Okay, some may just have the 72-hour one. Okay.
Just to say, the study was for accessing the pill on a Sunday. It's not generally in Gozo.
Oh, I see. Okay. Because they were coming back to us telling us, listen, in Gozo we have it. We checked. We want definitely to know how the service has developed. We're all for giving a service, but we're also all for safeguarding the right of some pharmacists to conscientiously object, that's all, even if it's the 72-hour one, because they have a right, and they have a right, and it should be guaranteed. But as I said, the access to the service should also be guaranteed. So there, I think we have to work on. That is where we have to work on.
We're
So, Emma,
not to strip pharmacists of the right to conscientiously object. That's all. Would be in this case, would be in other cases. I mean,
in what way would it be possible to increase that access, in your opinion? So definitely. Yes, Emma, go for it.
I feel like we've skirted the question a little bit, because I would expect that a pharmacist with as many years of experience as it takes to get your degree, again, you know, Nizalkom il-Kappell, amazing. I know it's a hard course. I have friends who've done it. You would expect that there's rationale and logic, and
there is, I'm sure.
I agree with you.
I assure you.
Had you told me that the 72-hour one that has no research contrary to it is in stock in every pharmacy, I would have believed you as well. But unfortunately, without that, then the concept of conscientious objection continues to lose legitimacy. And that's all it is. I'm not saying that it shouldn't exist. It should exist, but it should be rooted firmly in science. And that's,
of course.
it isn't.
Science and conscience. Let me tell you, the oath of the pharmacist is nippratika bi kuxjenza u xjenza, jew xjenza u kuxjenza. Xjenza, insomma, one or the other. What comes out, chicken or the egg, okay? Both are important. Issa, with regards to the two preparations, okay, the decision to dispense, so let's leave conscientious objection out for the time being. Decision to dispense depends very much on the answers of the woman in front of you. So many times they're not very clear about when they took it, when was the last, the information about their ovulation, you know. It's it's not always very clear cut, of course. All right. So that may, I'm saying, you know, I'm trying to put myself in the place of a pharmacist, okay, who consciously objects. All right. That may put the doubt in the pharmacist's mind, even from a scientific point of view. Okay. And they decide that they do not want to stock neither one nor the other. That's it. And they have a right to do that.
So, Emma, a final point, please. Yes?
Sorry, I'm talking. Are you talking about the fact that a person who wants the morning after pill comes into the pharmacy, asks for it, the pharmacist asks the questions to ensure that it's the right medical choice, and then they conscientiously object? Because I was under the impression that the conscientious objection comes before.
No. Conscientious objection comes before. Conscientious objection is a decision that comes before.
Precisely. So what?
If you present me, let's say, you know, a company presents with a product, all right, you look at the scientific evidence about it, and you make your decision. I mean, not when they. But that's why they make that decision.
So abroad, it's quite common practice that a healthcare professional can object. However, they would be obliged to refer them to another healthcare professional that can provide that service. What is your opinion on this when it comes to the MAP being distributed?
I already said that is part of our guidance.
So that is agreed upon.
Sorry, but
That's
that's
agreed
part
upon.
of our guidance, which is based on we looked at what happens internationally. However, there's also recommendations for changes to legislation that we have seen, which advise that professionals can also not do that. However, the state should provide access to a legal sexual health service or reproductive health service. I mean, that is in addition. However, our guidance is to refer.
Since it is currently simply guidance rather than mandatory, do you believe we should be moving in the direction that it does become mandatory? That the pharmacist refers.
Because this is a question. No.
That would I think
mandatory. No.
It could be perhaps be argued that
a professional guidance is a professional guidance.
Okay.
Yeah,
Any other points?
Can I add something?
Yes.
Yes, I really do feel, I have to emphasize this, that as health professionals, all of us, we have a duty to care for persons who need us. And it is not enough, it's not good enough to say that my personal conscience does not allow me to dispense the morning after pill. Neither will I refer. That to me is simply unacceptable, because if you, for whatever reason, you decide that you cannot dispense this morning after pill, emergency contraception, you absolutely must refer. In fact, I would go further. I would actually put a sign outside the pharmacist, outside the door, that says, emergency contraception not available here, but it is available in the next, wherever the next pharmacy is. In other words, I would impose upon that pharmacy a responsibility to provide the information about where they can obtain it. Maybe it should get on a website somewhere, but at the very least, we don't want persons standing in the line, standing in a queue, waiting to speak to the pharmacist, finally finding out, sorry, I won't give it to you because I'm conscientiously objecting. That should be known before you enter the pharmacy. Just like, when you enter a grocery store or a shop, it says, these are not acceptable, not accepted here. Actually, that's a silly example, but MasterCard not accepted. There's no point in walking in with your MasterCard.
Don't compare a pharmacy to a shop, please.
Sorry?
Don't compare a pharmacy to a shop.
No, I'm not comparing it. I'm just saying the service. I'm saying
well,
no.
You can be in a queue waiting and then coming.
Let's let Prof. Stabile finish her point, please.
Out of stock too. Some medicine can be out of
Continue,
stock.
Prof. Stabile.
Yes, I'd like to just say that in this case, this medicine is not, we're not talking about an out-of-stock medicine. We're talking about objecting to dispensing a medicine which is available in another pharmacy. Since it is available in other pharmacies, what is stopping this pharmacy from putting a sign outside the door to say, if you want the morning after, if you want emergency contraception, please go to, that pharmacy. Because you don't have to say, I'm not going to do it, but you can say, please go somewhere else. I'm sure that your members, would be willing to do this. Let's ask them.
Well,
why not? It makes sense to me. Why should we have to wait for something we know we can't get? Anyway, that's my point.
Let's conclude on this topic. Any last remarks? So, Sam? You're muted, Sam.
Okay, I should be unmuted now. I just want to add my humble opinion. I think we just need to stop normalizing denying access to healthcare to women, because essentially this is what it is. Any way you look at it, you deny women access to the morning after pill or contraceptives, and then it ends up a woman on I've spoken to women who took all the necessary precautions and then they have ectopic pregnancies and they can't access necessary drugs because it is considered abortive. They're having these unnecessary surgeries. It's all interconnected to me. So the sooner we can provide decent, accessible contraceptives, excellent standardized sexual education, and eventually, of course, the decriminalization of abortion, the better for everyone. And with that I yield.
Yes, Emma, let's make this the last point on conscientious objection.
No, I'm not going to talk about that again. I'm just going to finalize and sum up. I think what Sam said is completely like on point. Further to that, it needs to be established that there is, I mean, we know that there's a huge stigma surrounding sexual health. I mean, one just needs to look at the percentages of people who actually visit the GU clinic, for example, not even going into the issues that the GU clinic faces. When you consider the stigma that already exists, it would be prudent, I think, to also consider the stigma that having medical professionals and health professionals like pharmacists denying you the morning after pill and what that does to contribute to that stigma. And again, as Sam put it, I yield at that. Thank you.
Okay, so any final remarks?
On this point, or just to wrap up?
Just on this point.
Oh, no,
we wrap up after.
I'll let you continue.
Okay, so I think from our end, that's it. I don't know if there's anything you'd like to add to finalize about sexual education and contraceptives and access to contraceptives. So the floor is yours. I'll give you a couple of minutes each to bring up your last points. Yes, Sam?
Professor Stabile would like to go first.
No, you go, Sam, go.
Okay. To wrap up on this, I've been following this issue quite closely because this is to my heart, and I am a journalist, so I'm allowed to, bug politicians about this. I know that of course sexual health has taken the back burner because of the COVID-19 pandemic, but I know that there is a fresh sexual health policy in the works. Unfortunately, as civil society, we won't have necessary channels perhaps to add pressure. So we need doctors and healthcare professionals to lobby themselves and add pressure to the technical committee who will be drafting this up. Of course, if there's something that will have to be passed through Parliament, then of course, we have our role over there, and we have our role to keep shouting and make sure our voices are heard. But we have a real prime opportunity now. Young people, make your voices heard, join civil society, doctors who believe that this needs to be taken seriously, healthcare professionals. We have this window now to radicalize and for the better, sexual health in Malta. And this is our opportunity. So let's get the fight on.
Thank you, Sam. Prof. Stabile? Yes, I'd like to add to that. First of all, I'd like to invite anyone listening to us today, watching our discussion today, if you wish to join, become more actively involved in the pro-choice movement, whether you are a student or whether you are a professional, then please reach out to one of us, because there is place for everyone here. So just send one of us an email and we'll put you in contact with the right group. But speaking, wrapping up the whole issue of contraception and access to care, I did want to mention that in August this year, together with two other voluntary organizations in Malta, we, as Doctors for Choice, have launched a volunteer-run service, which provides free, unbiased information about how to access contraception in Malta, and of course also how to access abortion abroad. This service is called FPAS, Family Planning Advisory Service. I'm going to advertise the telephone number if I'm allowed to. It's 2778 2758. We believe that this service is beginning to help people think differently about the issues surrounding contraception and abortion, and changing women's experience for the better. Believe it or not, since August, one person a day has contacted us asking for information, which we provide. So I think we can safely say that services are now available for women to access. What we need now, of course, is to be able to provide those services more directly. And thank you very much for the opportunity to participate today.
Marian?
I was under the impression that the discussion was on contraception in Malta and on the legal services that are provided in sexual and reproductive health. I'm glad to have taken part in this discussion. And I would like to say that the pharmacist is there to give a service. They give a service day in, day out. They are frontline, and in this COVID-19, they have given they are still there and they're very resilient. They are open to support women and others who approach them in helping to educate them in sexual health. And however, the Camera tal-Ispiżjara, the Malta Chamber of Pharmacists, of which I'm president, will continue to support pharmacists in retaining their right to freedom of thought and conscience. And also, however, to support and help the Maltese citizens and young persons especially, and all women and men and others, to have an up-to-date sexual health policy. So we will be contributing to the discussion, as Sam mentioned, with regards to civil society being involved. Chamber is also part of civil society. And all in all, it is very important that there is a strong education, because through education, that is empowerment of everyone, and especially of women.
Thank you. Emma?
I don't want to go on for longer. I've already spoken far too much. I just want to make one last point that a friend of mine, Desiree, brought up in a recent webinar about how important it is to make sure that when your politicians come knocking on your door asking for your vote in the coming months, you tell them how important it is to you that sexual health is placed on the national agenda. As we know, with politicians, it's important that they know how we feel about it. I'm not saying don't vote if they don't promise you the world and a half when it comes to being pro-choice. There are other important facets of why we vote. So everyone should always vote, but make sure you make it unequivocally clear that this is important to you and you bring it up, because without doing that, we're never going to actually make a tangible change. Thank you for having me.
Thank you, Emma. Thank you all for joining us. It was a very interesting discussion. Obviously, contraceptives, access to contraceptives is definitely a hot topic in Malta. Obviously, we did go into abortion, which was not really the scope of the discussion. However, it is definitely an interesting topic. I think that definitely whatever anyone's opinions are, we should be having these conversations. Any opinion is valid. And I really, really hope that we continue to talk about these things and highlighting them on a stage, especially as university students, to continue seeing where Malta is going to go in this direction. Thank you all. I hope you have a lovely evening. Thank you also to all our viewers.
Thank you.
And a special thanks to Elsa Malta and the MHSA who are supporting this initiative.